Cool. Okay. Once again, hi everybody. My name is Mazen, and I'm going to be presenting to you the new sodium glucose transport 2 inhibitors. I wish that I could be kind of disconnected from all these wires and be more interactive with you all, but this is my setup for today, so please excuse me. So let's get started. So I have this really cool presentation set up for you all, and let's get it going here. So this is the layout. We're going to be flowing through all these slides, and I'm going to be navigating through the computer in this way. So first of all, let's go over through some of the overview of what we're going to be talking about. So I'm going to go through some of the characteristics of type 2 diabetes, some of the current things that we have available to treat diabetes. I'm sure you guys are all aware of those. And then not only am I going to go through the current therapies, but I'm going to go through the future therapies that are kind of in the pipeline. And then we'll talk about the newly approved diabetes medications, which this presentation is about, and some of their advantages, disadvantages, and some of the raw data pertaining to those medications. So let's start out with, so how do we treat diabetes today? You know, we have three main mechanisms or three main occurrences that we see in diabetes. The first being, you know, persistent hyperglycemia. The body is experiencing these high blood sugar levels, and in response, the pancreas starts to release insulin, and it releases so much insulin, so much so that it becomes burnt out, it becomes tired, and over time, due to an unhealthy lifestyle, being overweight, and lack of exercise, we develop insulin resistance. So those three primary occurrences are what we kind of want to target when it comes to diabetes. So how are we targeting them? What are we doing nowadays to kind of get these three primary occurrences under control? Well, we have this really cool diagram here. It kind of splits up some of the main categories of the drugs that we kind of use. It looks a little crazy, but it's not. On the left, we can target glucose production. We can target glucose absorption in the intestines. We can, you know, even target peripheral glucose uptake as well. All these things are basically, see where those arrows are going? All those things are trying to restore that new normal glucose level in the body. And that's what we continually are trying to do. So let's see what the future medications in development hold for us. Currently, there's about 128 new medications in the pipeline, and all these range from inhaled insulin, which is really cool. I'm sure you guys, I don't know if you guys have heard about that or not, but from inhaled insulin all the way to PTB1B inhibitors. Now, I highlighted PTB1B inhibitors just because me, as a young undergraduate student, I did my undergraduate research in PTB1 inhibitors in school. So I'm really excited to see that these drugs are kind of in the pipeline now, and I hope to see them come to the market. So moving on to what we're going to be talking about today. So the newest drugs have a very new mode of action that I think is, you know, so interesting. But first, to understand how this new mode of action works, I want everybody to kind of understand a really important concept. Our bodies, this italicized statement, our bodies have evolved to never waste food or energy. And every time we treat diabetes, we're going against a very fundamental evolutionary trait that are genetics that our body has developed. So in this case, every day almost 180 grams of glucose is filtered through the kidneys. And then see that arrow going back? They're filtered, and then all of it is reabsorbed back into the body. Again, it's this concept of never wasting energy, never wasting nutrients, never wasting sugars. All these vital sugars are filtered through two transporters, SGLT2 and SGLT1. SGLT2, if you see that 90% there, that's where the majority, that's the transporter that has the majority of glucose reabsorption capability. So what do these drugs do? They block SGLT2. And in turn, that's going to block the reabsorption of glucose back into the body. That's why the arrow goes back. So I want everybody to kind of understand that concept because it's a little it gets a little fuzzy if that's not elucidated. So let's see that in a more diagrammatic fashion. So again, how do these drugs work? They're targeting the kidney. They're targeting the reabsorption of sugar in the body. So what are we causing? Glucoseuria. So normally, again, glucose is filtered and reabsorbed. We block this step, and as a result, glucose passes out through the urine. So you get like a kind of sweet urine per se, sugar urine. So let's look at this in a video. I'm sure a video will, speak 1,000 words. So I have this really cool video for you guys. See if I can zoom into it. Yeah. Do we have sound? No? All right, I guess I'll be the sound. So on the left and the right, this video should have audio, is the body, and we're going to be zooming into the kidneys. So within the kidney, this is the nephron, and this is where all the glucose is filtered and then eventually reabsorbed. Here we go. So this is the proximal tubule. You have glucose flowing through in the blue, and you see those two transporters right there? They're all reabsorbing the sugar back into the body. And then per Dr. Lee's request, we have a more schematical view of this kind of diagram. So again, this is the nephron. Glucose is filtered through, and the drug in this case, that glipizin, is blocking at that purple site right there. So glucose eventually is excreted in the urine. So I hope you guys take a moment to appreciate this kind of figure. I know it looks a little loopy. And then I'm going to bring your attention back down to the bottom of the slide. So we naturally do this in our body. The SGLT2 transporter gets overwhelmed in diabetes, and the threshold for that is 180. So when the blood glucose reaches 180 milligrams per deciliter, the body starts to excrete glucose in the urine because the transporters can't handle that much reabsorption. They don't have that much reabsorption capabilities. So again, the glucose then spills out in the blood. So we kind of are promoting that weakness in the body. So let's move on. So let's look at some of the pros and cons. What are some of the good and some of the bad effects that these drugs can cause based on the mechanism of action that we kind of just saw? So advantages. Well, we get weight loss, which is a very good advantage. As we saw earlier, you excrete glucose in the urine, and the amount that you excrete is between 70 to 80 grams a day. So I have this really cool picture here kind of showing you how much approximately 70 grams is. And if you all go by the notion or the principle that every gram of glucose is equal to 4 calories, then 70 to 80 grams would be about 200 to 300 calories per day. So that's a relatively significant weight loss that we see with these drugs. And again, it's because you're urinating sugar. And furthermore, we also see a drop in blood pressure. Why? Because all this glucose in the proximal tubule is pulling in water, because water is following the glucose. It creates an osmotic diuresis per se. So when that happens, we release water and sugar out of the body. Our blood pressure thereby decreases. The mechanism for this is not completely elucidated, so it may be more complicated than this, but we have yet to see what exactly it could be. So again, these drugs also have the advantage of having a low incidence of hypoglycemia. Why is that? Because they're insulin independent. They're not doing anything with insulin. Nothing is touching the pancreas. Nothing is touching the liver. We're primarily working inside the kidneys. So that is very advantageous. They also have low CYP3A4 interactions. We're going to touch on that in the pharmacokinetics section as well. And lastly, they can be used alone, again, because they work independent of insulin and all these other therapies that we will see later. So what are some of the disadvantages? Again, a lot of these things you can kind of see through their mechanism. Why do we have urinary tract infections? Why do we have genital mycotic infections? Because bacteria love sugar. So if we have all this sugar in the kidneys, who's going to go there? You know, who's going to kind of be attracted there? And that's why we see this kind of incidence in urinary tract infections, genital mycotic infections. But I noted here that we already see in diabetic patients, we already see an increased incidence of, you know, urinary tract infections and asymptomatic bacteriuria. So that's already kind of present in that population. And this side effect in studies didn't happen too often, and if it did, it could be properly managed, it was expected, and it could be recognized early. So again, dehydration. Why are we getting dehydrated? Because we're releasing sugar and water we're releasing them outside of the body. So in turn, we can get hypotensive, we can get hypovolemic, and you can have you intuitively want to be cautious with loop diuretics and other diuretics that the patient may be on. Again, may not initiate, I don't know how much this pertains to us, but you may not initiate these drugs in a creatinine clearance of less than 60 for dapagliflozin or less than 45 milliliters per minute in with panagliflozin. So why is that? These drugs rely on adequate renal function. If you can't put glucose into the proximal tubule, if you can't put glucose into the urine, you have nothing to block. You have nothing to reabsorb because there's no glucose there in the first place. So as filtration goes down, as we see here, efficacy goes down. So we wouldn't initiate these drugs in those kind of patients. Lastly, dapagliflozin. That's the only one that has this bladder cancer risk, and I wanted to highlight that for you guys as a major disadvantage. But that remains to be elucidated. We'll see more on that in post-market studies. But I just wanted to mention that in this slide. So moving on. So we just went over some of the pros and cons. Let's go into the two new drugs that were just approved. So there was canagliflozin approved in 2013, and then dapagliflozin in 2014. They came in 2 dosage strengths each. And the first one being 100 milligrams for canagliflozin, and it also comes in a 300 milligram strength. And dapagliflozin comes in 5 and a 10. So how should we take these? How should patients be instructed to be using these medications? Well, in studies, this is how they were kind of studied. So this was the recommendations. These were the recommendations in the package inserts. So again, this is what they recommended. One of the main points that I wanted to highlight was there's one main difference, and that's that dapagliflozin can be taken with or without food, and we'll allude to that again in the PK section. And that's kind of a good advantage, I would say. So moving along, so we saw how we should take them, who should not take them. So these drugs are contraindicated in patients with severe kidney problems and patients on dialysis. I'm going to ask you again, why won't it work in these patients? If we can't filter glucose, we have nothing to block to reabsorb again. So again, they won't be efficacious. You can't filter efficiency. There will be no sugar to excrete if the patient's kidneys are not working. So, and also limitations of use are in patients with type 1 diabetes and diabetic ketoacidosis. I think that's mostly because they haven't been studied heavily in that area, but that's something that I wanted to note as well. So let's go into drug-drug interactions. This is a very heavily pharmacology-oriented slide, so please I'll try to go over it as superficially as I can. So in this first section, we have absorption, distribution, metabolism, and we have some of the compatibility that these drugs, some of the drugs that these drugs are compatible with. So for the first one, I want to talk about absorption. We can take these drugs with or without food because food doesn't alter the absorption relative to people who are fasting. the AUC, the area under the curve, I don't know if you guys are familiar with that term, compared to a person that's fasting is not significantly different. They did see slower absorption, but none of that was clinically significant. So again, these can be taken with or in terms of dapagliflozin, can be taken with or without food. And again, you want to take them before meals, like we mentioned previously. Another important cool point is in terms of distribution, these drugs are protein bound, but they're not altered in patients with hepatic impairment. And when I say renal impairment, I mean, of course, greater than the last things that we were talking about, greater than 60. And hepatic impairment is really interesting. I did more research on this. So in terms of distribution in patients with severe hepatic impairment with a child Q score of A, B, or C, they saw a huge decrease in AUC from 12 all the way up to 65%, but no adjustments are needed anyways because that data wasn't significantly or clinically meaningful. Patients still experienced similar effects as people who had a healthy functioning liver. Thirdly, we have the metabolism and elimination. These drugs are eliminated via the kidney, via UGT glucuronidation. I don't know if you all are familiar with that, but I'm just kind of breeze through it. And then in terms of metabolism, they don't really have too many drug interactions because they're not metabolized by the liver. They're metabolized by the kidney primarily. About 61% is eliminated through the kidney or the renal pathway. But they do have issues with things that can lower the levels of these medications in the blood, and those things would be UGT inducers like rifampin and phenytoin, etc. I added this last point in there because on the package insert for dapagliflozin, they noted that it doesn't alter the pharmacokinetics of other prescribed type 2 diabetes treatments, and also those drugs at the bottom there, simvastatin, valsartan, warfarin, etc. And I thought that was important to kind of see that, hey, you can use these drugs in this case and not have to worry about some of these main culprits here. So that was a heavy slide. Take a moment to take a breath there. So let's go into, now we're going to swing over to one of the treatment arms. So to the left, you're going to see canagliflozin. To the right, you're going to see dapagliflozin. We're going to start out with canagliflozin and go into some of the raw data and clinical trials that we see with these drugs. So first one is canagliflozin. So what do we know about how good they are? We know they have this great mechanism of action. We know they have all these good advantages. We know some of their PK. Give me some of the raw data. So here in this study, canagliflozin was studied versus placebo, and this is the study design here: RCT, double-blind. The primary endpoint was change in AUC through 26 weeks, and again, this is provided that all the patients had adequate renal function, and this was in patients whose A1C was about 8%. So pretty formidable treatment study. You saw about 1.16 reduction in A1C, which is a pretty good reduction. I wanted to note the placebo at the bottom, 21%. We saw 21% of an effect with placebo. So that kind of makes me question, how good are these drugs really if almost a quarter of the patients still saw a reduction while they were taking placebo medication. So let's move on. So we saw their effect on A1C. I also wanted to put in their effect on HDL. They have the benefit of raising HDL. And again, the improvements in HDL are likely related to the improved glycemic control, the weight loss, and all those other advantages that we mentioned. But note that it can also raise your LDL. So in speaking with Dr. Lardenois on this slide, in the study, they noted that the mechanism of LDL increase was not really known. But we know that if you decrease triglycerides, or excuse me, if you decrease triglycerides, then the LDL will increase. So that could possibly be a mechanism as well. But I just wanted to highlight that point for your guys' reference. So lastly, for canagliflozin, how does canagliflozin compare to current therapies that we have today? How do they compare to DPP-4 inhibitors, for example, sitagliptin? So in this study, I really like DPP-4 inhibitors. That's why I included this slide. They're one of my favorite kind of diabetes drugs because they're relatively safe, and I wanted to see how they compare to those drugs. So in this specific study, you saw a statistically significant drop in A1C, and it was even a little bit more than sitagliptin, almost 0.37 more greater drop in A1C. And I thought this was a relatively fair study. People might say, you compared canagliflozin 300 versus sitagliptin 100 milligrams, but you compare the max doses of both drugs, so should be a relatively fair trial, in my opinion. So yeah. So again, this was for canagliflozin. We're going to literally swing over to dapagliflozin, and we're going to answer more questions about how good they are. We've seen their glucose lowering effect. We've seen their beneficial reductions in A1C. We've seen that they have some additional benefit in HDL. Let's transition over, to kind of answer a little bit more questions. How do they compare to sulfonylureas? Weight reduction, how much weight reduction? What about hypoglycemia? When I said they lower blood pressure, how much do they lower blood pressure? So these are some of the outcomes and studies that looked into those things. So when it was compared to glipizide, it was found to be non-inferior. There were statistically significant reductions, or statistically similar reductions in A1C versus the sulfonylureas. And let's zoom into that slide. So if you look at the bottom, the length of the time on the bottom, it has in weeks from 0 to 104 weeks. We know that sulfonylureas lack glycemic durability. So over time, even though they both achieve similar reductions in A1C, you see the sulfonylureas in the gray start to lose ground, whereas these drugs maintain their effect. And so that's why you see that separation after 52 weeks. So that's something that I kind of wanted to mention in terms of that sustained effect, that sustained glucose lowering effect with these drugs, which will come apparent later when we talk about weight loss, because I have a really important point I want to mention. So let's move on. Again, versus glipizide, non-inferior. Let's move on to their effect on weight. So as we mentioned, we know they have weight reduction. Let's see how much weight reduction. In this study, they were compared as an add-on to metformin, glimepiride, and insulin. I really like this. This depiction, this graph. It's not as amazing as it seems, because we know with sulfonylureas we have weight gain or weight loss. We have weight gain, right? So it's not as cool as it looks, because sulfonylureas you experience weight gain, and with these drugs you experience a moderate weight loss, about a 5 kilogram difference. But something that Dr. Lardinwall highlighted and made me kind of think about, and maybe I can kind of relate with you guys as well, is look at the bottom line there. After 26 weeks, you plateau. Why are you plateauing? Why are you not continuing to lose weight? I mean, you're peeing, you're urinating sugar, you're losing calories every day. You're losing 200 to 300 calories every day. All this glucose is being excreted in the urine. Why isn't this line going down still? Why is it leveling out? Is the body homeostatically responding and saying, okay, well, let's just make more sugar. We're excreting more, let's make more. Or, it could be, there's so many reasons I guess you could think of, but I thought that was a very, very cool and important point to kind of highlight, is why don't we continue to lose weight? So let's see how they look versus insulin, because that's something that's probably going to be important. I like this slide as well. If you can kind of decipher some of these things, you see on the left, you have dapagliflozin and insulin plus other oral glucose-lowering products, and you have placebo plus insulin and other glucose-lowering products. Here we see the opportunity to reduce insulin use in patients who are on chronic insulin therapy. In this study, patients lost weight and they decreased their insulin use by 2 units, whereas people on placebo increased their use of insulin by about 5.6 units without dapagliflozin. So I thought that was relatively impressive as well. So that was their effect on weight. Let's move on to their effect on hypoglycemia. In this study, dapagliflozin was compared to glipizide. Again, not too amazing here. I'm not really impressed by this slide because we all know sulfonylureas like glipizide have an increased incidence of hypoglycemia. So when you compare it to something that's not insulin independent, works in the kidneys, I mean, this is not too great of a difference. So I looked into it compared to placebo, and that's the little segment at the bottom. When compared to placebo, you had a relatively similar hypoglycemic risk, 4 to 3%. So not very much hypoglycemia with these drugs at all, which is great. So effect on blood pressure. We know that they lower blood pressure. How much? This was going head-to-head with glipizide again, and we saw almost a 5 millimeters of mercury drop in blood pressure. I mean, that's great. I'm not too impressed, again, because this was over, 52 weeks? So almost over a year. I mean, still beneficial, and something to kind of highlight. Also, Dr. Lee showed me a really interesting article. It was, just had came out during my making of this presentation. And basically what I gleaned from this article is that this blood pressure lowering effect is a class-wide effect. It's not just, for these drugs. This study had about 5 SGLT2 inhibitors, canagliflozin, dapagliflozin, empagliflozin, all those drugs, and they saw similar reductions in blood pressure. So that's a positive thing to kind of remember. So we just went over some of those things. Again, those outcomes were for dapagliflozin, and the previous ones were for canagliflozin, just to kind of give you guys a 360-degree view. So all in all, we see the glucose lowering effect occurs irrespective of what these agents are used with, whether it be metformin, whether it be a DPP-4 inhibitor, whether it be insulin. And we also see that overall benefit in weight loss and systolic blood pressure. So what's their place in therapy? Again, the key difference with these drugs is that they're insulin independent. So what does that do? That gives us the opportunity to use these drugs over the progression of diabetes, at many different stages of the progression throughout diabetes because of them being insulin independent. The ADA has not yet commented on these drugs yet. It's not in the guidelines. Apparently ACE has. I'm not too familiar with what exactly they are noting, but I was told to note that they had made some comment. Again, they're useful as add-on and monotherapy, as we just saw in those studies, and they are available in a combination pill with metformin and canagliflozin. It's called Canamet, but that's only available in Europe. It's not available in the U.S. yet, so we can watch out for that. And I like point number 5. If a patient can't tolerate metformin, I think it would be a nice combination to have them on a DPP-4 inhibitor and a SGLT2 inhibitor. I think it would be a relatively strong pairing combination for those patients who have stomach upset or whatnot, or contraindicated to metformin. And lastly, in terms of place in therapy, we can't use them in patients, again, who don't have good kidney function because these drugs won't work. So lastly, in conclusion, these are just some summary points, some of the things we went over. And I'm going to keep saying them, so hopefully you guys all got the main points of the presentation. These drugs can be used alone or in combination with some of the drugs that they were studied in, metformin, sulfonylureas, DPP-4s, and insulin. They're advantageous because they are only taken once a day. and you can also take dapagliflozin without regards to meals. But generally, it's recommended to take them in the morning before the first meal of the day, just because they have this potential to lower those postprandial high blood sugars, especially if you take them before you ingest those sugars. They have relatively formidable A1C reductions, 0.5% to 1%, as we saw, with little to no hypoglycemia risk. And the most common adverse effects that we see are in terms of the genitourinary system. We see those increased incidence of UTIs and mycotic infections. And lastly, they're contraindicated in patients who have end-stage renal disease and on dialysis. Those patients should not be on these drugs. So I hope that summarized these drugs enough for you guys, and I hope this presentation was, informative and helpful. And I really do appreciate you guys taking the time to kind of listen in. I'm really impressed with you all. You guys all know a lot, so I'm happy to be here and privileged to have given this presentation to you all. So thank you. I don't know how to stop it. It was weird talking with this thing. I don't know if I was talking too loud, but I couldn't really hear myself, so I had to take this
You were
off.
good.
Yeah, I'd be happy to entertain. There's only one person on there, right?
There's only one?
Go.
I'd be happy to entertain any questions if anybody has anything on their mind.
They're gonna type it.
Oh, they're in type. Okay, SGLT2 inhibitors can increase hepatic glucose production. So that's why it would be important and imperative to have an incretin mimetic on board. So that's something that I was made aware of. There was a bunch of studies that showed almost a 25% increase in hepatic glucose production with these drugs, and that's a really important point to kind of remember. So an incretin mimetic should be on board. Okay. I can't wait to see how they explain the plateau of the weight loss. I think that's really interesting. That was brought to my attention.
Mm-hmm.
I think that's really interesting. So. What do? So if I understand this question correctly, it's asking what studies show in terms of relative difference between UTIs with this medication and UTIs in the standard diabetic population. I'm not too familiar with those statistics. I can get back to you guys on that. I'm sure that the incidence with these drugs, I think I noted in the slide, was about 2 to 8%. I'm assuming that that was an increase relative to placebo, which would have been patients not on SGLT2 inhibitors and with standard rates of UTI. So I hope that provides some benefit, but I can definitely get back to you.
Any other questions?
Nope, doesn't look like that.
You can conclude. Go ahead and conclude.
Okay, if there's no more questions, I'd like to conclude this session. Thank you guys all again for attending, and hope to present again soon.